if you have to leave. I don't have a hard stop. I'll finish the lecture in that amount of time, hopefully leaving some time for questions. And I'm happy to stick around if people have any further discussion points. So first, thank you for joining me today for clinical decision making for older patients. Over the years, most of you here know about what I do, but many of you have asked me to add this sort of format to my offerings, and this is the first one I thought I would try, and no better way to test a concept than to make it free. And like I said a moment ago, part of the experiment on a free webinar is seeing who signs up versus who shows up. We're at about a little less than half now, actually. So, and I've been guilty of signing up for webinars that are free and not going myself. So I don't hold that against anyone. The interesting thing I noted is most of our attendees today are from Canada, because that's where I am, of course. But we also have a fair number of people from the UK and a few from Switzerland, France, and the United States. So as people are still joining here, wherever you are in the world, thank you. I sort of picked 12 Eastern time because that's typically when webinars are in Canada, which allows those on the West Coast to join us in the morning. And, Central Canada is usually on lunch break or something. If you're in the UK, you're probably near the end of your day, and also in Europe. So thank you for joining me. Today, we're going to talk about clinical decision-making for older patients. And this is based on partly on a lecture that I was asked to do as part of a multidisciplinary conference a few months ago that went through an interesting case. So we're going to go through a few different things in terms of the literature today, talk about a clinical example or two. And if you have a question, you can feel free to drop it in the chat. Drop it in the chat, or we can actually, if everyone's brave enough, we can go cameras on at the end for questions if you wish. So most of you are aware that my job in chiropractic is to help you guys translate science into practice and figure out what to do with the volume of literature that comes out. And some of you on the session today may have taken my full day course called Older and Bolder, Chiropractic Care for Healthy Aging, which dealt with a lot of concepts related to the care of elderly people and conditions that affect elderly people. And the decision-making part of it is always interesting. And so part of this content was borrowed from that. And as you'll see, I've added some recent examples from the literature to help us clarify what we know about a few things. So my goals today include going over a couple of special considerations relating to the care of older patients and how that may impact our optimization of management decisions for these patients. Obviously, they deserve some special attention, some different forms of care sometimes, and there are a myriad of factors that we need to take into consideration to help optimize our treatment decisions for these patients. For chiropractors, it often boils down to kind of a simple question, and that is, should I adjust this patient? And I'm going to sort of start from that premise and extend a little bit into some other things that we do in terms of soft tissue therapy, and we'll mention a couple of other things as well. And also, start to touch on the concept that manipulation is certainly not the only thing that we can do for elderly patients. And I think there's a lot of value that we can add in some other ways. So we'll talk about that as we go. And I want to start from a simple premise, and that is that our goal as chiropractors in the context of helping people age gracefully should be to develop strong and resilient patients. And, in my practice, I didn't have a lot of elderly people, but the ones I had were, of course, similar to your practice, I'm sure, quite variable in terms of their fitness and their capacity and their health literacy and everything else. So the two people pictured in the image today are by no means the norm, but our goal should be to facilitate continued activity, improved function, and just generally improving the capacity of our elderly patients to live their lives and continue performing their activities of daily living, and also fitness activities, living independently, and all sorts of different aspects of their lives. So we'll talk about how that can vary as we go through today. I just wanted to give you a little bit of context before we start. We know that musculoskeletal conditions cause the most disability and also drive the need for rehabilitation services in older adults. The World Health Organization and other major governing bodies around the world have identified access to rehabilitation services as a major need in our healthcare system and something that will be of critical importance going forward in our healthcare system in terms of patient flow, economics, and preventing untoward health outcomes for people. So and a lot of these concepts apply to younger patient groups as well. But to say it this way, like it kind of hits different with elderly people. And we'll talk about that as we go through the day, through the session as well. We know that low back pain, as our primary example of a musculoskeletal condition that we address and manage as chiropractors, peaks in the sixth decade of life. It's incredibly common and disabling, of course. And the global incidence, according to the newest data coming out of the Global Burden of Disease Project, shows us that low back pain is not going to get better. It's in fact going to get worse. And you can partly ascribe that to the aging sort of bubble of baby boomers that are coming through the healthcare system now. What we also know about low back pain, especially in elderly people, but also at any age, quite frankly, is that especially when it's chronic, it can correlate with all kinds of other comorbidities like cardiovascular conditions, mental health conditions, sleep disorders, general functional decline, frailty that we'll talk about in a few minutes, and so on. We also know that one of the major limitations in caring for elderly people is that a lot of older patients don't seek or simply do not have access to care. As I mentioned a moment ago, the very concept of access to rehabilitation services is a very important concept that the World Health Organization is paying attention to as well. And we have some of our main researchers in Canada, Dr. Cote and his team, looking at access issues and how implementation happens in various provinces and throughout Canada. And similar work is going on in other countries as well. We also know from recent randomized trials from Michelle Myers and colleagues in the United States that elderly patients generally love the combination of manual therapy and exercise and activity. Or rehabilitation. And I think that's an important concept for us to embrace as a profession as we serve this patient population and make sure we get them moving more tomorrow than they're moving the first day that they see you. And I think that's a critical goal for us. And part of my blue sky vision for how our profession can impact the health of aging people and improve health span in addition to lifespan going forward. The World Health Organization, specifically relating to the care of older patients, advocates for a holistic, person-centered, equitable, non-stigmatizing, non-discriminatory, integrated, and well-coordinated approach to patient care. And I think, as I said a moment ago, most of the attendees today are from the United Kingdom or Canada, and I think our healthcare systems are facing similar challenges as far as I can tell from the data I've seen. I think it's fair to say that primary care models are generally overwhelmed, and I would respectfully add that they need our help, provided that we behave consistently as a profession and implement evidence-based, person-centered care. And you see examples of that all over the news almost every day in terms of doctor shortages, nursing shortages, waitlist times for surgeries, and that sort of thing. And as I said a moment ago, also, those factors affect all age groups, but just hit a little bit worse in elderly patients, unfortunately. So we also know from Cecilia Bergstrom's group and their recent survey of chiropractors relating to the care of elderly people specifically, that chiropractors believe that we can provide timely and effective treatment for this patient population. We can fill a substantive gap in primary care and help smooth things over, I think, in terms of patient flow, appropriate referrals, minimizing treatment escalation in terms of reducing unnecessary advanced imaging, injections, opioid medications, and that sort of thing. We have big data in that area in almost all age groups now. And also to help focus on preventive treatments. I mentioned my blue sky vision a moment ago for the care of elderly people. And I think it would be really amazing if all senior citizens, and let's call that over the age of 60 or 65, it's semantic for the sake of this argument. But what if all saw a chiropractor once a month for a half-hour session where you were able to manipulate, mobilize, traction, some soft tissue work, check in on some simple rehabilitation and balance exercises. And then in the intervening 2 weeks, they got a full body massage from a registered massage therapist, which would perception, peripheral neuropathy, and all kinds of things. I think our governments really need to start looking at those models of care for our patients. We also know and identified in this survey that chiropractors identified barriers to access that their patients expressed to them. And that includes just simple access to chiropractic care or other rehabilitation services, having the personal resources to pay for that care, and also the integration with their other members of their healthcare team and what happens to them in the context of their healthcare scenario and what other doctors they're involved with and so on. So, the perfect system and the perfect algorithm isn't there at this point necessarily. But I think if you reflect for a moment on the elderly people that you see in your office, one of the things I tell our colleagues whenever I speak about this is that sometimes our bar for success that we set for ourselves is a little bit higher than what an elderly person's bar for success is in terms of how they view the success or failure or implementation of our treatment strategies. And that's something we have to keep in mind. And I think if you back up to a 30,000-foot view of that, if we help this population in general and are able to reduce a percentage of falls, as an example, via maintaining joint proprioception, hip mobility, foot and ankle mobility, and keeping people in simple rehabilitation streams where they're able to improve their balance, function, strength, and coordination, that has massive downstream effects in the healthcare system in terms of cost and patient morbidity and outcomes and so on. And I think that's something that we have to be very cognizant of going forward and really strive to implement in healthcare systems that, at least from where I sit, are now starting to come to us for help because they've realized that the current status quo is not going to work for them. And I think the time of true integration into healthcare for chiropractic is coming sooner than we think. And I think we have enough data now and enough clinical experience to very much support our inclusion in these sorts of systems. My goal for us is to make sure that we're compensated properly for this and that the patients enjoy a seamless integration and that we're in there helping patient flow and management and outcomes, of course, while being successful as individual practitioners. So let's talk about optimizing management decisions with older patients. And to me, a lot of this boils down to good doctoring and being able to be cognizant of the fact that, let's say, if you're a chiropractor of my age and you're mid to late 40s and you've been in practice for 20 years or so, you probably notice that some of your patients have been with you for that long and might actually be about the same age as you. And when I talk to veteran chiropractors around the globe, a lot of their patients sort of reflect their age and stage. And I think we naturally become cognizant as we age that bodies change, spines change, joints change in terms of their adaptability, their ability to withstand treatment, how they respond to treatment, and so on. And I think that's an important thing to consider, whether you've been with someone for 20 years or you're meeting them for the first time when they're 50 or 60. And I think putting their age in context, and as I'll talk about in a moment, their functional age versus their biological age can assist you in treatment making or in treatment decision-making processes. So this is the way I think of this in terms of approaching clinical decision-making, things that are relevant to the patient individually, things that are relevant to their clinical context as they may present to you in your office, and also the procedures and techniques that you may use in your practice. So if we start with just some general concepts about seeing elderly patients, I've been banging this drum for years that I think for all new patients in a chiropractic office, we need to take a little bit of extra time for an initial appointment. And I think elderly people have certainly earned the right to have a bit more of our time and attention on a first visit. And that allows you to get a little bit more information, build a little bit more rapport with the patient, and develop a therapeutic alliance. It's a topic for another day, perhaps, but There's a lot of evidence now relating to the impact of therapeutic alliance on patient outcomes. And the best way to facilitate that early on in a patient relationship is simply to take time to be with them and hear their story and understand their context and their healthcare landscape, as I have in the second point there. What I mean by that is, what kind of support do they have available to them personally? Do they have a caregiver? Are they able to take care of themselves? Do they live independently? Do they have a family doctor? And no matter where you are these days, it seems family doctors are overstressed and underpaid and having a hard time taking care of their patients. So, for some of you in practice, you might be the only healthcare provider that a patient comes across in a 3-month, 4-month, 5-month period. And I think, respectfully, that changes your responsibility level for that patient in terms of monitoring general healthcare things, vital signs, blood pressure, and that sort of thing as well. So that's just also something to keep in mind. The other thing we have to keep in mind with elderly patients is, have they had chiropractic care or any manual therapy before? And I think that's a very relevant discussion to have with any patient at any age, quite frankly. But you'll also get a good indication of whether they're comfortable with being touched in that manner, if they're familiar with kind of the techniques that we use. And I've always been a big proponent of explaining what we do to our patients before we do it. And, surprise adjustments are never good for anybody, but having a frank discussion about, have you ever had manual therapy? Has anyone ever moved your spine around? Have you ever heard a popping sound? Do you know what that is? Are you worried about that? Are simple ways to sort of get to their experience level and see, how they might respond to your care before you start. And you might also be able to address some of their concerns, whether their concerns are legitimate or not. And if you don't have that conversation, you simply don't know. And the last point there is biological versus functional age. And I think we're all aware that not every 65 or 70 or 75-year-old is the same. And I think that speaks to their physical fitness, their nutrition, their general health. Do they sleep? Are they happy? We'll talk about that more in a few minutes. And I think that's something to also consider when you're deciding, what sort of treatment package am I going to offer this person? Is it going to include high velocity manipulation, or would they be more comfortable with mobilization to start based on their experience with manual therapy, their comfort with touch, and so on? These are the three things I'm going to talk about in a little more detail in a few minutes in terms of clinical context. And it's comorbidities, polypharmacy, and frailty, which are all things that can drastically affect how patients respond to care and may affect your decision-making process in terms of, do I adjust this patient? Does this patient need to be referred for a pharmaceutical evaluation to see if their symptoms are related to drug interactions? And can this person, frankly, withstand physical therapy and treatment? So we'll talk about those more in a moment, but other contextual things to keep in mind, like I mentioned a moment ago, their living conditions. Does this patient require being able to go upstairs, for example, to get to their bedroom or to the bathroom or whatever, depending on their individual situation? Do they have help? Do they have a cleaning lady? Are they responsible for that sort of thing on their own? Movement literacy simply means, are they comfortable moving around? Is there any degree of kinesiophobia that you may have to address? Do they have a history of being an athlete or exercising, or do they actively exercise at the moment? And the other part of that I think is critically important is to help you understand as a practitioner whether this person understands the importance of movement. And I found that to be kind of a generational gap that I encountered in my practice over the years, where some elderly people weren't raised in the generation of CrossFit and men's and women's health magazines and Peloton and sort of all the different exercise things that are thrown at us all the time. They don't really understand the connection between my physical literacy, my physical health and movement, and how my back feels. And I always think of I'm half Dutch, so I had an Oma who passed away when she was 98 a couple of years ago. And when her back started bothering her, she had lumbar spinal stenosis. She simply never really connected the idea that movement might be helpful. She's like, well, it feels better if I don't move. And that's something that we often have to combat in these patients. You also have to think about some things like finances and proximity. So when you recommend someone of any age, quite frankly, these days, to come and see you 3 times a week, I'm sure you start to see like their wheels spinning about, how the hell am I going to do that? I have my kids to take care of, or if they're a senior, I have my social clubs. I have lunch with this person. I don't have a car. I can't drive anymore. How am I going to do this? And also, in most cases, on most of the people attending here that might watch it after, they have to pay for your services mostly out of pocket sometimes. So we have to keep that in mind as well. And then the last point is simply a healthcare point, and that is if this elderly person is in your office and they haven't seen anyone for a long time, do you have time here to assess their overall health and lifestyle and how their back pain might fit into that? Or are you concerned that this person has a red flag condition that needs to be assessed urgently? And that's something and sort of a thought process we have to go through with all of our patients. But I think it's relevant to mention that here with elderly patients. And I think one of our strengths as a profession is that we have time to get to know people. But our first job on a first appointment is to do an adequate and sufficient intake to understand if there's anything urgent or that needs to be referred or managed from a red flag or other sort of urgent matter perspective in their clinical scenario. And then from your procedures, documentation is always important. One of the things I do is medical legal consulting when chiropractors end up in lawsuits. So I do review a lot of files. And, I always say to my colleagues in Canada, at least, write your files as if someday I, as an expert, may have to explain what you did to a patient to a judge or a jury. And just make sure that the story is complete and that there are historical factors and a relevant history documented, physical examination, how you arrived at your diagnosis, informed consent, of course, and then laying out the roadmap to their management plan. Um, are there any red flags present? And is there anything, like I said a moment ago, that we need to be urgently aware of? Be useful and efficient in your examination. And I say this no matter what the age. And this is to avoid what I call the rotisserie chicken effect on the table, where you're asking this elderly person to lie on their stomach. Now lie on your back. Now lie on your stomach. I forgot this test. Oh, I got to flip you over one more time. Patients hate that. I think patients hate that at any age. So have in your mind after your history what physical examination you need to conduct, and make sure you do it in a way that makes physical sense for them as well. And also keeping in mind whether this person has a history of being examined. And I think one of the things we have to remember these days is that medicine has kind of abandoned hands-on examinations in lieu of advanced imaging and all kinds of different diagnostic tests. But patients sort of need to be used to being moved around and how that might feel. So be very mindful of that with all patients, but especially elderly patients as well. Have an opportunity for a thorough discussion, and make sure you're an advocate for them and that you're communicating clearly with other healthcare providers that may be involved in their care. So again, we just want to think about individual patient factors, the clinical context around that individual person, and then your procedures in your office to document your care. So let's get to the three things I was going to touch on: comorbidities, polypharmacy, and frailty. Starting with comorbidities, there are a number of comorbidities, of course, and I think as people age, it's natural to expect that their healthcare landscape gets a little bit more complicated. I think patients in general at any age are getting more complicated these days. But it's not unusual now to see a lot of different conditions walk through your door packaged up in one human body, which again speaks to my prior recommendation of giving yourself a little bit more time and being a little more thorough with these patients to the best of your ability and scheduling capacity. So a lot of the common comorbidities that we see, this is from Lisa Killinger's paper. She's a colleague of ours that was at Palmer when she wrote this paper about comorbidities commonly seen in elderly people. And they include things like depression, nutritional factors, and general endocrine factors like anemia. We'll talk about adverse drug events and polypharmacy in a moment. B12 deficiency is very common in elderly people as well. Unstable medical conditions simply mean blood pressure that isn't being managed properly, neurological decline that isn't being assessed and managed properly. And then the big ones for us as chiropractors are kind of the next four. And that's all varieties of arthritis, which include primarily osteoarthritis. We also have things like spinal stenosis that are increasingly common in elderly people and should be on your differential diagnosis list after the age of 60 or 65 for people with increasing back pain. Osteoporosis is very common in elderly people, and it can happen in men and women. There's always kind of this thought that it is more common in women, but it's also increasingly common in men. Then sarcopenia, which is really just a decrease in muscle mass and a correlating, decline in function. If you want to think of it that way. The other reality for elderly people is that those pathologies that we all learned about in school can become a little bit more prevalent in terms of metastatic or primary cancers and other organ dysfunctions that might cause spinal symptoms. A good example would be prostate issues in old aging men, or heart or lung issues in men or women as they get older. And one of the things that Lisa didn't talk about in that paper that I've seen a bit more work done on recently is loneliness. So I added that to the list, and I'll touch more on that in the next slide. From a sort of chiropractic overall health perspective, one thing that always struck me about dealing with elderly people is that we don't consider the last things I added there comorbidities, but I always have. Honest, I think a lot, and I've seen this in my wife's grandmother and my grandmother's as well, that dehydration can really make elderly people feel terrible. And in some circumstances, they're on a collection of medications whereby a doctor will say, my wife's grandmother was a good example. She had chronic kidney issues. And her doctors would say, well, you don't want to drink too much water. That'll just stress out your kidneys. Well, guess what that does to grandma? It makes her lethargic and tired and almost dizzy and not seeing properly and so on. So I think these lifestyle factors that we are so good at integrating into our programs of care can be critically important for elderly people. And one of the things relating to nutrition that ties into elderly care so often is that they simply just don't eat enough food. And especially if they live alone, if they're a widow or a widower and don't have their partner to eat with and cook with anymore, that's something you'll often see a lot. And then other regular things we talk about with patients like sleep, stress, and fitness. I mentioned social support and also loneliness a moment ago. And the reason I add this is because we're starting to see a lot of data come out now about the clinical correlates of loneliness and social connection and social support as it relates to elderly people. Just as we're starting to see a lot of concerning data come out about younger people and the lack of social connection that they have. But sticking to the topic today, most older adults report having fewer friends and a smaller social network. And as you know, I said a moment ago, my Oma lived to be 98. And I remember her saying to me, maybe when she was in her early 90s, she lived in a retirement home by then and had good friends there, thankfully. But most of her other friends that she had outside of that life in the retirement home had all passed away. So there's a little bit of attrition that unfortunately happens as you get older in terms of your social network. But the data is showing us that loneliness as a construct is reported by over 40% of the elderly. So it's approaching half. And the reason we need to be concerned about that is it predicts negative outcomes, including mortality. And it's a clinical association has been noted with chronic pain, obesity, smoking, immune dysfunction, hypertension, and psychiatric disorders. So, I've read in different books about aging before that if people have a reason to live, they will. And part of that reason is their social connection. And it's something that we're just starting to measure a little bit more in elderly people and people of all ages, quite frankly, and recognizing the importance of it as a correlate for general health and perhaps a proxy for good health as well. There's other data showing us that loneliness can accelerate neurocognitive aging and someone's chance of having dementia by about 1.6 times. And if you think of it, if grandma or grandpa, I just use them as generic elderly people examples, don't have anyone to talk to all day long, you can see quickly how the live wire system in the brain starts to fray a little bit. And there's no interaction, there's no stimulation. And that's what I mentioned earlier, like the bar of improvement is low for a lot of people. So a stimulating conversation for someone who lives by themselves can actually be a good jolt of neuroplasticity or live wiring. I've heard it referred to now as how the brain connects and how it stimulates growth and evolution in that sense. So I just add this here as part of something that we should be asking patients about, if not on a first visit, within the first couple of visits, just so we get some idea of what their social landscape is like. So let's dive into polypharmacy. So let's start with the concept that this is out of scope for most of us. Fine. However, I think we see patients that are entrenched in the healthcare system, seeing multiple healthcare providers, and I think it behooves us to be well aware of the impact of polypharmacy, when to recognize it, and refer back to the medical providers that are in charge of that pharmaceutical regimen for an individual patient. But so being aware of it is important, and knowing when to act on it is also important. And I think it's a very important treatment decision-making process to go through with elderly patients, because it's easy to forget about at the same time. So traditionally, polypharmacy is defined as being on 5 or more medications. And the average person 65 years and over in North America is on 6 to 8 medications. For those in the UK, I think that data is quite similar over there. And polypharmacy is known to be more common in those who have multiple medical providers, which isn't surprising. The more specialists you have, the more comorbidities you have, quite frankly, and the more likely you are to be on different medications for those conditions. If we back up for a moment in my world about, when people say, what is the evidence to support chiropractic? That's a discussion I'm happy to have anytime, especially these days. But this is a good point to pause on polypharmacy and ask the medical profession, like, what is your evidence for having someone on 8 medications for 20 years? And they simply don't study it and don't really know. So you see things like too many medications, inappropriate medications, bad combinations where one is sparking a side effect or an adverse drug event in the other, or medications being used to treat the side effects of other meds. One of my jobs in high school was to deliver for a drugstore in Stratford, Ontario, where I grew up. And so I would drive this little truck around town and take elderly ladies, mostly, their pills for the week. And it was a DAW set, like one of those plastic things full of, here are your pills for the morning and the evening and so on. And the pharmacist would split them up. And these things would be full of pills. Like some of these people were taking 20 something pills a day. And I would always completely inappropriately ask them, like, so what are these for? Because I would see them every week, right? I would pick up the old one, and they would also forget to take a lot of their medications consistently, which doesn't help either. But ask them what they were for, and they would go through the laundry list of, blood pressure, fluids, my sugars. They would always say sugars, and this one's for my pain. And then they would go off into, well, this one's for the side effect of that one, and this one's the side effect of that one, and so on. And that was one of the factors that made me decide not to get into medicine, to be quite honest with you. And because the second question I would ask them is, how do you feel? And almost across the board, they would say, I feel terrible. And I thought, well, I don't really want to do that to people. But I think what we see in clinical practice in a lot of our patients is a direct reflection of this, and we should be aware of it. From an older adult perspective, the last point there, they're more than twice as likely to visit an emergency department with an adverse drug event. That's ADE. And we know that monitoring of their drugs, we'll talk about in a moment, prescribing or deprescribing, and adherence to taking their drugs can each contribute to the increase in adverse drug events seen in that patient population. We also know that there's a direct correlation, bidirectional association between physical function and polypharmacy. So the more drugs people are on, the more likely they are to experience reduced function. What to look for in your patients includes things like reduced alertness. And just for the record, a lot of these symptoms might be something that are harder to assess if this is a new patient for you. But our job, if you see people over time, is to be aware and cognizant of recognizing the emergence of symptoms like this so you can act accordingly, refer back to the family doctor, suggest, maybe we should take a look at the medications they're taking or see if we can adjust things. Other things like confusion or cognitive problems, falls or accidents, weakness and dizziness, loss of appetite, gastrointestinal problems of any flavor, skin rashes, and depression. And one thing I would add to that list is musculoskeletal pain. Statins are a very common drug class. Most elderly patients are on a statin of some sort if their cholesterol is out of whack. And one of the most common recognized side effects of statin medications is actually musculoskeletal pain. So again, all of this kind of out of our scope. However, I think it is well within our ability to recognize when this might be an issue and discuss it with patients and facilitate discussion with their medical providers. Just so you know, at least in Canada, the recommendation is that elderly patients have an annual medication reconciliation meeting with their doctor to go over all the medications and pharmaceuticals and also supplements that they're taking to screen for interactions, adverse drug event potential, and even to look at deprescribing, which I think most of us would probably chuckle when I say that, because a lot of elderly people, once they're on a medication, they tend to have to stay on it. But just so you know, it might be worth asking your patients, like, when was the last time you sat down with your medical doctor and talked about your medication regime, to see if any of this might possibly be contributing to how you're feeling these days, or the progression of this symptom or that symptom or what have you. But it's in their scope of practice. It's in their clinical recommendations. In my experience, it wasn't commonly done. I think, one of the problems is that geriatrics is one of the most needed medical specialties on the planet, but it is wildly unpopular in medical school for people to want to specialize in geriatric care for any number of reasons. But one of the things for us to consider as chiropractors is this a factor? Do they need to speak about it? And one of the basic fundamental things of elderly people sometimes is that they become physically unable to take their medications. So some people have a problem swallowing pills at the best of times, and that can, of course, get worse as you age. So just something to keep in mind. Last thing I'll touch on is frailty, and it's defined in a couple of papers in a way that I think make a lot of sense. The first definition, frailty is an impairment in mobility, balance, endurance, physical activity, muscle strength, nutrition, and cognition. And it's the overarching geriatric syndrome. The second definition that I like is it's a state of increased vulnerability that develops as a consequence of the accumulation of microscopic damages in many physiological systems that leads to a striking and disproportionate change in health state, even after an apparently small insult. So what we're talking about here with frailty, as it's considered in the literature a syndrome or a state of accumulated health deficits. It's kind of like death by 1,000 cuts, right? Someone has an ankle injury and can't work out properly in their 70s. All of a sudden, they're not able to work out properly at all. And I think most of you will have patients or relatives or parents who have gone through some version of this when they have a healthcare incident or a surgery or an injury or a fall that really kind of knocks them back a level or two. And it's a matter of reducing their physiological reserve and increasing their susceptibility to other injuries or conditions. And that's something that we have to be mindful of with all of our patients. In the literature, there are a couple of different ways to think of a frailty assessment. One of the simplest ones I like was just reviewed in the Kim and Rockwood paper that was in the New England Journal of Medicine a couple of months ago. And looking at frailty as a constellation of potential symptoms, including exhaustion, which is often the first thing that you see, weakness, slowness, physical inactivity, and weight loss, which is usually considered to be a later manifestation. If a patient has a couple of those features, one or two, they're considered to be pre-frail. And if they have three or more, they're considered to be in a frailty state. And as I mentioned, and as is pretty obvious, that will have severe implications in terms of what you can do to them from a manual medicine perspective and how you might address their physical activity and other aspects of their care. So, how does this boil down to what we do in a chiropractic office when we're talking to our patients and deciding what to do with them? As I mentioned earlier, one of the best questions and things to discuss with them on the initial intake is their experience with chiropractic care and manual therapy in general. And I underlined chiropractic care in the title of this slide to emphasize that the benefit that you procure to your patients as they age has arguably less and less to do with the actual manual treatment you provide them and more to do with the actual healthcare experience that you provide them. When you look at data on healthcare satisfaction, one of the most common complaints people have is that no one listens to them, no one spends time with them, and that no one touches them anymore. There's now, as I said earlier, kind of an absence of touch in allopathic medicine that I think highlights one of our strengths as a profession, that we still employ touch in our practice. So do they have experience with chiropractic care is a very important discussion to have. And if we boil it down to my other question, do I adjust this patient or not with a high velocity technique? First, is it indicated? And do you think that the patient's spine or musculoskeletal system can withstand that sort of force? Is that sort of force necessary? So is it indicated? And I think in elderly people, it's also a good question to say, is it not contraindicated? Are there any contraindications there that we need to be cognizant of before we progress? Then you have to ask yourself, will it help this patient more than some other form of care? And can I get to the same improvement in mobility without introducing a higher force into the system? Which brings us to the third point there. And what about mobilization? This is anecdotal, but in my experience, my aging relatives and my elderly patients in my practice sort of much prefer mobilization. Not all of them, to be clear, but some of them have a declining preference for high velocity over time and think that mobilization, kind of traction maneuvers, a little bit slower, a little bit low force, repetitive, seems to work better for them. And I think that's something that we have to discuss with our patients over time and assess in terms of our own opinion of how they're progressing through care, what might be best for them. If we expand it into other things that we offer, like soft tissue work or modalities, you can look at things like their general sensitivity. Do they have peripheral neuropathies that might get worse if we put TENS pads on them, for example, or use some other type of electromodality? And can their skin take, hard soft tissue work, or are they on blood thinners, which a lot of elderly people are? So they might have additional or excessive bruising with interventions like acupuncture or various forms of soft tissue techniques and so on. And, I think all of these are valid things to think about as you approach what kind of treatment interventions am I going to use with these patients. As I said earlier, I think it's about a balanced approach with our elderly patients, recognizing that manual therapy is just one thing that we can offer. And it's worth remembering that the evidence base around the care of elderly people from a musculoskeletal perspective is kind of in its infancy. There was a whole period of, once evidence-based medicine was born, so to speak, in the mid 90s, most of the studies have been done on patients age 18 to 60. And we don't have a lot of data on randomized trials for musculoskeletal conditions or anything for elderly people. And that's starting to change. And most of the evidence that's coming out is quite favorable in terms of chiropractic care for elderly people. But I think it's worth remembering that there isn't a lot of evidence for polypharmaceutical approaches to treating general health for elderly people. And I think there are a lot of bits and pieces in the evidence that suggest that manual therapy at certain intervals, including hip traction, mobilization, spinal mobilization and manipulation, soft tissue treatment, could be a really fantastic idea for our elderly patients. For you as individuals, we shouldn't limit ourselves to one intervention. And remember that being an exercise and movement consultant as people age is a very valid thing to include in their care and can be very helpful for them. So just try and balance your approach with a patient based on their experience, their comorbidities. Is polypharmacy an issue? Are they able to withstand care? Is this a spine that needs a high velocity manipulation or a low velocity mobilization? Is there anything else I can address for this patient? Do they have social support? All the factors that we touched on can help you decide what's best for them at any given point in their care journey. So I wanted to finish with a quick case example just to get you thinking about this. This is a 78-year-old female patient, an existing patient of yours over the years who has had prior high velocity manipulation to her lumbar spine and thoracic spine, but you hadn't seen her in about 8 years. So since she was about 70, so she shows up at your office. She was shoveling snow on her front porch. She still lives in her own house by herself. 2 days earlier, and she experienced acute midline interscapular pain. She reports as painful in all movements, but especially with flexion. And with flexion, she experiences radiation of pain, sharper pain around her left rib cage. Couldn't sleep that night. As a good chiropractic patient, she tried ice, and despite all the evidence that Tylenol doesn't do anything, she tried Tylenol, but said it didn't help with her pain. A little bit of health history on this patient. She was a smoker for 34 years, but quit 9 years ago. You have in your file that she had a bone density test 12 years prior that suggested mild osteopenia at that time. She was not a particularly fit or previously active individual. Saw you for prior mid back pain and low back pain that responded well to manipulation. And when you asked her, as you should, as a good doctor, is there anything else new that since you hadn't seen her in 8 years, like how are you feeling? How's everything else going? She did report a couple of things that may require a bit of further thought here. One was that she had a recent non-productive but lingering cough. She's not sure why that happened. She says she doesn't feel really sick. She just seems to cough for no reason, and she feels a little more tired than usual. And that's that's a tough one to interpret for some elderly patients because it's a very common symptom that they report. When the injury happened 2 days ago, she went to a walk-in clinic because she's in Canada and her family doctor is unable to see her. And the physician on duty at the walk-in clinic diagnosed a muscle strain and decided to do a cortisone injection locally on the left side in between her shoulder blades. This doctor also prescribed an NSAID and referred her for x-rays and said to her that she's clear of any significant pathology. And we'll circle back to that in a moment. She said her pain between her shoulder blades was a bit worse after the injection, but was a bit better when she woke up the morning after, which is the day she came to see you. Your examination revealed range of motion limited globally, and it was kind of all painful for her in her upper back. She had multiple trigger points in her interscapular region or tender areas in the musculature that you would identify as trigger point. If you asked her to take a deep breath, she had relatively sharp pain at T4 to T6, right in her most painful area. Your upper limb neuro exam was normal. No vitals were performed. We'll talk about that more in a moment. And the x-rays weren't yet available. So she went for the x-rays, but there was no report available yet. And you diagnosed acute mid-back pain with muscle hypertonicity, which is not inaccurate. But at this point in her care, based on her history, based on the fact you hadn't seen her for a number of years and the other things we've talked about, just give a moment to think about what you're thinking about for this patient and what might be going on. One of the things you should have in your mind is based on the mechanism of injury of loaded flexion with arm extension and movement for shoveling, she may have a vertebral fracture. So jumping back into the literature for a moment, as I tend to do, what are the best red flags for vertebral fractures? And unfortunately, this is from a Cochrane collaboration review done in 2023 or published in 2023. Most of these red flags have poor diagnostic accuracy individually, but the combination of factors seems to be better. The best ones that come out in the literature are steroid use or a history of steroid use, which this patient does not have, an age over 74, which she is, trauma, which you could consider the shoveling incident its own form of trauma, and external bruises or scrapes on the body, which would be more of an emergency room kind of diagnosis if someone fell, for example. So the literature here, not entirely helpful except for her age, but I think practically speaking, we have to look for things like, are there any red flags here? And I hope you also identified, she smoked for a number of years. She has kind of a weird cough at the moment. She had acute pain with a physical activity that she was doing the snow shoveling for the first time that year. So you look for red flags plus a mechanism of injury, plus the temporality of the symptoms. And I think that's the best clinical approach that we can take. So ultimately, to wrap up the case part, x-rays came to you the next day and revealed that she had a compression fracture at T5. And unfortunately, there was an upper left lung mass that required some advanced imaging, and her whole spine appeared osteopenic. And to the best of your x-ray viewing knowledge, that was not due to an exposure issue on the x-ray. And, there's of course now concern that there's a pathological fracture there, and she should have some degree of osteopenia or bone density measurement done as well. So this is a referral aspect or a referral case that should have some further assessment, hopefully before you've inserted your treatment into that timeline. We'll talk about that more in a moment. But the issues that also come out of a case like this, and this is something that always bothered me when people would have an acute injury and go to a walk-in clinic or an emergency room, and I've seen this in legal cases too. For example, emergency rooms will send home a patient with a disc herniation. I've been on legal cases where it's happened multiple times. And then it turns out they end up needing surgery, and there was a delay because they were sent home. So, this idea of what constitutes medical clearance is always a little bit concerning for me. I don't really know if it's defined in the literature. I don't think it is. I don't necessarily trust the context and the history with a patient that a walk-in clinic doctor might have, with all due respect. So I think our job is to never sort of trust this idea of medical clearance. And in this case, the X-rays weren't available to you, so you waited to see what they revealed. And of course, now there's a compression fracture. Now there's a problem in the lung that we need evaluated. So hopefully, your decision process there would be a wait and see approach. In this particular case, vital signs may not have revealed anything, but I think, as I said earlier, with your elderly patients or any patients, quite frankly, especially if you're in a more rural area where their access to family physicians might be reduced or infrequent, that helps drive your decision making. Like, am I the blood pressure person for this patient, or do they have regular medical care? My practice was in downtown Toronto in an affluent neighborhood. Most of those patients were actually at third-party medical clinics like Medcan, Medisys, the Cleveland Clinic, and so on. So I definitely wasn't their blood pressure doctor. But you have to ask yourself, in the context of the healthcare landscape, to circle back to that concept, are you the person that's responsible for that? And ultimately, when you think about, do I adjust this patient today? Is there a benefit risk ratio to think about for waiting versus intervening? And I think in the case that we just went through, there's enough information there that would at least suggest to me that waiting would be the best approach. And I think that's something that you have to address on an individual basis. And at the end of this hour and this topic, unfortunately, I don't have a perfect algorithm to give to you in terms of, when do we adjust a patient and when do we not? But I think there are lots of factors that we've covered and discussed that should help you along the way in terms of figuring out what combination of manual therapy and movement therapies might be best for this individual patient, and also what degree of doctoring, let's say, do you have to do for this patient? Are you their only healthcare person that they interact with on a monthly or quarterly basis? Do you have contact with their medical doctor? Is there someone kind of quarterbacking their care? I won't get into a diatribe here about how we need case managers in our healthcare systems, particularly for elderly people, to quarterback information flow among specialists and communication flow to different practitioners or chiros or physios that might be working with an individual patient. And, part of my other blue sky vision is, what if we were all using the same electronic healthcare records? Okay. What if your patient came to you and you had access to their clinic notes from their rheumatology visit 2 months ago, and you even knew that they had a rheumatology visit 2 months ago and what the diagnosis was, what medications they're on, and so on? I think that's something that the technology exists for, and something we really need to be aware of and look into in terms of future healthcare record keeping among multidisciplinary care. As multidisciplinary care gains popularity in the literature and in practice, albeit entirely too slowly, I think that's something that we have to visit as healthcare professionals. So, as always, the decision that you make with your patients should be based on the best research evidence that's available, and what sort of things that we know about are in the literature, and the patient values and their particular context, and also your clinical expertise. I think the reality of the situation for most of our practices is going to be this: you are going to have a higher percentage of elderly people in your practice in the coming years. That's just the natural bubble of patients that are coming through our healthcare system at this time. And I think that's something that we have to embrace as a profession, help to improve the function and capability of our patients and help improve their lifespan. And as I said earlier, build stronger, more resilient elderly people going forward. So it's always a bit of a clinical decision making process that you have to go through with yourself, with your clinical experience, with your patients, and hopefully with some knowledge about what the evidence can tell us about the decisions that we make. So that'll wrap up the formal part. The next webinar I'm hosting is on December 12th. There is a charge for that one, $24.99. My idea with this, if people want me to do it, is we'll meet for an hour. If there's enough demand, eventually I can add a second session in a given day later in the day for those on a different coast or a different time zone. I'm not against that idea, but for now, I'm going to roll with 12 o'clock Eastern time because it's sort of in the middle of a bunch of different time zones and availabilities for people. In the next webinar, we're going to talk about extra spinal causes of low back pain. So kind of the weird and wonderful organ and systemic conditions that might wander into your office with low back pain and how you might identify them. And the next one I had scheduled in January, on January 23rd, is on cervicogenic dizziness and how to recognize the impact of the neck on dizziness and vertigo. So one of the other things I want to employ here is these 1 hour segments will give me a chance to cover, kind of more obscure clinical topics that may not show up in a full day seminar, for example, or a 5 to 8 hour e-seminar that I post on my website for continuing education purposes from an e-learning perspective. So if those of you attending have any requests or ideas for what I should cover, then I would actually enjoy the suggestions. My idea is to do one per month. And hopefully we'll see if the response is good to this sort of thing and the commitment to meet for it and just to pay a little bit for it as well. So that's the next one coming up. And I'm also going to start posting a little more on my YouTube channel. So if you want to take out your phone for a minute, that's a QR code to my YouTube channel. I'm going to start adding some video content to smooth out the landscape about chiropractic on social media. And there's some interesting things going on. Not all of it is kind of the best look for us. I want to combat that a little bit with some common sense information and see what I can do there. So if you have any ideas on that front, let me know. And we're right at 1 o'clock now. The time is good. So if you have to go, I understand. Thank you so much for joining me. If you have any questions that are lingering, I'm happy to stick around for a few minutes and answer. So I'll stop my screen share here. And then if anyone has any questions, you can type it in the chat or jump on your camera. And if you have to go, thanks for joining and have a great rest of your day. Activator. We don't have a lot of evidence comparing the two, to be honest. I think both are viable for elderly people. It's a matter of patient preference, your comfort level as a doctor. I have no problem with the activator as an input. The only thing I would mention is sometimes the specific point contact on an activator, sometimes elderly people prefer a more broad, like hand contact. Do you know what I mean? So that if the patient likes it and you like it, then go ahead. And I wouldn't consider an activator a lighter force, high velocity. Just on your follow-up question there, it's a good question. There's some biomechanical data showing that activator puts a similar impulse through the tissue that a manual manipulation would. So unless you can put it as a different setting, but it's potato for me. If it's personal preference for you as a clinician, and if your patient likes it, then so be it. I have an activator sitting in my practice for years. But now that I only see private clients at my house, I don't have one. Nobody's asked me for it, but I used to use it earlier in my career, mainly on elderly people. So I'm not against the concept at all. Thanks, everybody. Any other questions? No? All right. Well, I'll sign off for today. Hopefully I'll see you next time. go to seanthistle.com for more information. And if you guys have any questions lingering after today, you know where to find me. So thanks so much. Have a great day. And hopefully we'll see you at the next one. Bye for now.